Friday, February 14th. Happy Valentine's Day, everyone. And this is House Healthcare. And this morning we're continuing our conversation around certificate of need. And we have in with us this morning Health First. So Susan, if you'd like to join us. Morning.
Good morning. That's showing, not yet. Really, I got kicked off. It does look like I got kicked off. All right, share. All right, perfect. Hi, everybody. Thanks for. Way off. Clearly. I think where my pink though. So, for the record, my name is Susan Ritson. I'm from Vermont Health First Independent Practice Association. And I just want to thank you for offering me the opportunity to speak about this topic today. And also want to thank Representative Cordes for helping us get this bill drafted, and also to Representatives Black, Burbico, Goldman, Fawn, Gina. I think I captured everyone. And then, of course, the other sponsors who have sponsored this bill. We think this is really important work. And my goal today is just to give you our perspective on it. And also, I've been researching this now for about a year. We decided to put something forward on this. So I'll share with you what the data says. We have 50 years of data now. So you have all seen this slide before. I won't go over it, but just tells who we are. And you might be wondering, well, why does Health First care about this issue? So I'll just explain some background here. My predecessor, Amy Cooper, and a group of our physician members are actually responsible for the Green Mountain Surgery Center. And, you know, it was at that time the physicians were really struggling. They were thinking, you know, patients really need more options for high value care, alternative sites of care. So they did put in the blood, sweat, tears, and money to get the Green Mountain Surgery Center going. And, as Mr. Mickenberg testified earlier this week, it was not an easy process. So, we're interested in this topic because we think meaningful reform will help decrease costs for patients, the whole system, businesses who are covering their employees, and the state in general might be able to get our property taxes down. We also, obviously it would broaden the number of healthcare options for patients, which Vermont really is limited in. You go to any other state and there are far more options for care, good options for care. And then importantly, having more options for care also broadens the options where healthcare professionals can work. And that's really important. In fact, the Green Mountain Surgery Center is responsible for actually recruiting, I think it's probably up to 9, maybe more physicians to the state because they had the option of working in that center, including Alyssa will be happy to hear, a plastic surgeon. I'm just gonna wear my thing. That is my started too. The other thing that doing meaningful con reform will do is just improve competition and quality, and I'll explain the link there. And then leveling the playing field. It's pretty well documented that CON laws tend to hurt the smaller providers who aren't as well resourced, able to, go through this process. So it tends to favor larger and incumbent providers. So I thought it'd be useful just to look a little bit at the history of CON, we can understand, where it came about. And it started in 1974 with this National Health Planning Resources Development Act under the Ford administration. And, they were trying to reduce healthcare spending. And there was this theory that, if we have hospital beds, there's going to be patients in those beds and they're going to spend money. So they were hoping to decrease the number of hospital beds and hence spending. They also were looking to restrain spending by encouraging alternative sites of care, basically. Also, we're interested in ensuring an adequate supply, especially for underserved and rural populations. And, of course, there's always the eye on quality that they were looking for, too. So that was 1974. And this act actually withheld federal dollars to states who didn't adopt a con program. So by 1980, 49 states had a program. You can see in these maps, the dark color are those with a con program, and the light is those without. However, by 1986, the Congress concluded that the CON laws really weren't working as intended. And they repealed the mandate and recommended that states basically get rid of their con programs. 12 did immediately. As you can see in 1990, a good chunk of states didn't have a con program. And this work continues to this day. We have the 2020 map there, but since 2020, there's been an additional 8 states who have significantly pared back their con programs or gotten rid of them. So Vermont isn't alone in this work. And just from an economist's point of view, a CON is basically a permission slip to compete. And it's designed to assess a need of a service in the market. And this is really unusual in a market economy. There's no other service that I'm aware of where you have to do that, go to a board. Your competition can oppose your project. It's just really unusual. And it is a barrier to entry, and it's widely recognized as being anti-competitive. And I'm not an economist, so I'm not even going to try and explain these. But as I've been, educating myself on this topic, I came across this video by Dr. Matthew Mitchell, who's a senior fellow at West Virginia University, and he's studied CON extensively. And basically, he's saying that con laws are acting just as basic economics 101 would predict. So we have this barrier to entry. So you're, limiting supply. That makes sense. So what happens to cost when you limit supply? It goes up. And that's exactly what the data is showing, that CON, limits access and drives up costs. So it's really not a surprise when you look at basic economics. And I encourage you all to look at the video that's linked here. It just really, struck me when I saw it. And then I'll just mention that, it's very widely recognized as being anti-competitive, and every federal administration since Reagan, which is when they told states they no longer needed to do con, has called for states to repeal the con. And you can see just a couple of letters. There's a joint letter from FTC and the U.S. Department of Justice. I think that was during the Obama era. It says con laws aren't succeeding in controlling cost or improving quality. Recommend that states repeal their laws. Same thing more recently in 2023, where they're citing that con laws are suppressing cost-effective and innovative and higher quality healthcare options, not controlling costs. And you can read that. I've linked the full papers there, but it's pretty well recognized that CON is not working as intended. And I know Owen Foster did present a map showing the states that have con programs versus those that don't. This shows a little bit different view of this, the restrictiveness of the different states' con programs. So the darker colors are indicating more restrictive states. And Vermont, by several measures that have been done, has one of the most restrictive programs in the country. We're ranked third for, or tied for third for the most number of regulated services. We have 25 regulated services. The highest is 28. So it's, you know, it's not nothing. And here's a list of all those regulated services. And some of the things on this list are things that we want and need more of. You heard Jonathan Reynolds from Rutland Regional talk about the linear accelerators. That's on the list. And so, you know, it does make sense to look at some of these things and just ask ourselves, does it really make sense? And con, you know, whilst we've been really heartened, we've worked closely with other stakeholders on this issue, including VAWS. And you heard the testimony from Rutland Regional. This is really an issue that affects various sectors of the healthcare system, and you know is hurting more than one entity, including patients, especially patients. Then I thought I'd bring it back to Vermont's con law and the stated purpose. And this is basically from Owens Foster's slides from last week, I think it is. You know, wanting to avoid unnecessarily duplication, you know, containing costs, also make sure we're maintaining and improving quality and access, and then promoting rational allocation of healthcare resources. Definitely laudable goals, right? But as you'll see in a minute, the data doesn't really support that con is working as intended. We have 50 years of data now, and we have states with con, states without con, states who have had con and gotten rid of con. So there's quite a bit of information out there. There's 128 peer-reviewed studies and 433 individual tests of different effects of CON. Looking at the first one, which has to do with access, there's been 83 tests assessing the effect of con on the availability of services. And you'll see here that the majority, 78%, do associate con with diminished availability of services. So it's pretty dramatic, I'd say. Go ahead.
Can you give us the source for this assessment?
Yes, it is linked in the presentation, but I'm happy to.
Down in the corner.
Yeah, but I'm also happy to, because you end up getting linked to the abstract, but I can share the full paper if you like.
That's fine.
Okay. And this is just Vermont does have an access problem. I know this isn't a news flash for anyone here, but this table just illustrates, and David Mickenberg spoke to this earlier this week, we're ranked 50 out of 50 for the number of ASCs.
Could you remind me what an ASC is?
Ambulatory Surgery Center.
Thank you.
Sorry for the using the acronyms.
We're a small state, so comparing us with everybody.
Yeah, no, and it's a valid
Sorry,
point.
I shouldn't.
No, it's fine. I welcome the commentary. So Green Mountain Surgery Center is an ambulatory surgery center. And I think it's pretty well recognized that that's a really great add to our healthcare system. And the states with similar sized populations of Vermont have 17.4 ASCs on average. And then you see our neighboring state of New Hampshire has 28, Maine has 15. So we really are an outlier here. And we're denying patients of, you know, high value options for care by not having more of these. And then this is just to drive the point home. We all know we have an access problem. There's some of the press that's been published on that. All right, so the next test is looking at the effects of con on spending per service. Because, you know, Vermont stated purpose for con is to contain or reduce costs. So what's the data say? And I'll just say that there's multiple ways to look at the effect of con on costs. This is spending per service, but there's also spending per capita and input output or efficiency. Happy to share that information if people want, but I felt like spending per service was most relevant for our situation here. So you'll see that 60% associate con with higher spending per service, or in other words, for every test associating con with lower spending per service, there are 9 associating it with higher spending per service.
Leslie,
I'm sorry if I missed this, I apologize, but I'm not sure I understand what the test is.
So there's 128 peer-reviewed papers, so
Okay.
research papers, and then each paper might have more than one test. So they're looking at the effect of con on, say, spending or access. So it's like a test, a theory, basically, or hypothesis that they're testing. Does that make sense?
Mm-hmm. So what you're saying is they're testing a hypothesis and then doing an unblocking on the term when you combine all the papers into one thing and do an analysis.
A meta-analysis,
Meta-analysis.
sort of,
So
yeah.
is that, I'm just trying to understand your methodology here.
Yeah, and just to be clear, it's not my methodology.
The
It's,
methodology
yeah,
you're presenting.
right, yeah. This is, this is from a paper by Matthew Mitchell, who's a PhD, who's been studying this for quite some time. So this is how he has chosen to look at it.
Mhm.
All right, and I know we've all seen this too, but just remind everybody, not that I have to, that we do have a cost problem here in Vermont. And then I just want to point out that, these independent freestanding centers are definitely more affordable. And this is real data, looking at prices from the patient estimate self-pay list of the local academic medical center compared with either the independent ambulatory surgery center or an imaging center that's here in Chittenden County, as well as an imaging center, independent imaging center that's in Plattsburgh. And you can see that the savings is significant. This is savings to patients. This is savings to the system, savings to employers. So to erect barriers for these types of centers coming into Vermont is when we have a cost and access problem, just seems maybe not the best thing to do. Any questions on this?
Casey?
I'm not clear how do I say this? I'm not clear, even given all the research, maybe I'm just not piecing it together yet, but how it can still be more affordable if, from my understanding, these ambulatory centers can be specialized in specific kinds of surgeries, which means if I need a pelvic surgery and I live in Rutland and the pelvic surgery center is in Milton, is that more affordable to me, given the fact that I need to travel for pre-op and post-op? What goes into these calculations? I guess that's the question.
Well, this is self-pay prices. So as far as how the prices get determined, especially on the hospital side, I can't answer that question. But I will say that generally the freestanding centers cost less because they are paid less by Medicare, first of all. So they need to be lean, mean, efficient machines. Not everybody can get a procedure in an ambulatory surgery center. You can't be so sick that you'd have to spend the night. So, the patients aren't as sick. But, that's okay. I do think we need these. If the patient doesn't need to be in a hospital, why pay the higher hospital prices for care that doesn't need to be done in a hospital? Let's pay the hospital for doing the great work that they do and we need them for, but let's not pay for hospital care that doesn't need to be done in a hospital.
So the savings are the savings to the facility for delivering the care, or are these savings to the patient on
Patient.
paying?
The patient and all of us, because we all ultimately pay for all of this, because we're paying for insurance and everything else.
But in these places, we're not paying a facility fee or something like that.
Yeah, I think like in the case of the Greenmount Surgery Center, and I probably shouldn't even answer this question because I'm not
Okay, don't.
that well on the technical details, but it's a one bill, basically for the surgery center and then one bill for the physician service. Whereas it's a little different at a hospital, they, can bill for ancillaries. In an ambulatory surgery center, it's one price and it includes everything. So you have that too. It's much more contained.
Thank you, that's helpful.
All right, so.
So I'm wondering, this is just being sort of a devilish question. If it is true, I see that the lower risk are going to the ambulatory surgical center, which then leaves a higher risk at the medical centers. How does that get offset? That they're losing that group of patients who pay a certain amount.
Obviously the whole system is pretty complicated, but again, why pay high hospital prices for care that can be delivered very
No, I
efficiently,
understand that.
cheaply,
Yeah.
in another setting?
Different question.
It is, I do, yeah.
It is a different question only in how the academic, the high risk, the more complex cases go one place, the low risk, cases go another place. How does that get balanced is what I'm wondering about. And I'm not expecting you to answer that. I'm just putting it on the table as a question of mine. How we finance both.
I think that's a hospital.
I think that's a hospital question.
Then I'd hopefully we can figure that out. I'm not saying I'm against looking at our CON process, because I'm for it, for sure. But I think it's a larger question than just this.
Yeah. It's like, it'd be better if people went to their primary care physician rather than the emergency room. It's the same sort of thing. It's much cheaper to go to the primary
No, not
care.
really. You're offering a structural change. And that's different than that example, but go on. I'm sorry to
Okay,
divert.
yep. So the next thing is test assessing the effect of CON on quality of care. And usually when the researchers are looking at this, they'll see if CON correlates with outcome measures such as mortality rates, readmission rates, infection rates, or if CON discourages the use of unwarranted procedures. And you can see here that nearly about 2.5 times as many tests associate CON with lower quality outcomes as with higher quality. So again, our stated goal for Vermont CON is to maintain or improve quality, and the data just doesn't support that. It's working as intended. And then last, our test assessing the effect of CON on rural and underserved populations. There's been 17 tests done on this. And again, 82% of the tests associated CON with diminished care for underserved populations. So in total, if you look at all of the 433 tests, 51% associated CON with a bad result, such as higher spending, less access, lower quality, diminished care for underserved population, less competition. And it's about 4 times more common than good outcomes, according to the data. Any questions about that before I go on? Is this helpful at all?
Yes.
All right, then for H96, I'll just talk about, our thinking behind some of the thresholds that we picked. And so we are recommending or support increasing the thresholds to 10 million for new and existing facilities for construction equipment and operating budget. We'd like this to apply to both hospital and non-hospital and not have disparate. Because again, CON is associated with, a lack of competition and helping some more than others. And then the other thing to note is that H96 applies that $10 million threshold to ASCs. But in the current statute, as well as Ginny's version of the bill on the Senate side, subjects all ambulatory surgery centers to con regardless of the cost. And we think that that needs to change. Otherwise, you have this barrier for ambulatory surgery centers. And then we felt it made sense to also increase the threshold for the conceptual certificate of need. So that's for these huge projects where you do need to do some planning first. So we bumped that up to 50 million. I think it was at 30. And we worked with VAS on this, and they suggested that state contracted projects be exempted, and we thought that made sense as well. And really, our goal was to make meaningful changes, but keep it simple and not get too bogged down in the details. Which I know, the healthcare advocate did talk a lot about process earlier this week. It's like I need to admit somebody, is that? Okay. So I'll just say a note about it. We totally agree that the current process is onerous. It's confusing, it's costly. I've been through it. It's not fun. It takes hundreds of pages of documents, a lot of research, rounds of questions, lawyers, time, money, and it's tough. It's definitely a barrier, I would say, to folks. I mean, in my position, I get calls from people, and I know con is a barrier to some of them. So we agree it needs to be streamlined significantly. We do suggest addressing that in a separate bill because it's complicated. And we understand the desire to want to review, especially larger projects. So I think we would be in favor of, just increasing the thresholds for some of these smaller projects and then dealing with the larger ones in process later.
Ellen?
Yeah, I don't know. We got the healthcare advocate here too, and yourself. I guess I'm going to use Art said, my little pea-sized brain here. Why are we doing this? Why is CON so important? I think I know what we're trying to accomplish, but we don't try to regulate this in any other field. So why are we doing it here?
I'm sorry, let me just clarify if I can. Are you saying, why are we
Why is
thinking of, why is this bill here
Yeah.
to change it? Or why do we do CON?
why do we do CON at all?
I think probably because at some point in the past, it was decided that we should. And so statutorily, we're required to do it.
Madam Chair, there's a
Yes.
purpose of the beginning chapter,
Oh.
if it would be helpful, we can look at that together after the testimony.
Okay.
It talks about our subject.
Yeah.
And it does sort of explain why there is a.
Yeah.
I just trying to get this.
And it was a reminder when we had the Green Mountain Care Board in here to talk about Act 167, one of the recommendations was around certificate of need.
I do, I understand all that.
Okay.
But that's an opinion from him.
What you're saying is your opinion is, why do we do this anyway?
Yeah.
Oh, at all. So you're saying you'd like to just like get rid of the whole.
I didn't say I want to get rid of it. I want to make sure that
Okay.
we're doing it right. So, okay, thank
Okay.
you.
Yeah, I don't think, we say we want to limit unnecessarily duplication of care. We want to control costs, maintain access, and improve quality and make sure resources are allocated, and the data just doesn't support that CON is working in that manner. So maybe we want to do something else, but yeah. So the key points in our mind is Vermont, we all know, has serious access and cost issues. Con is associated with worse access and higher costs and lower quality. So we think that passing this bill is low-hanging fruit that will help to address Vermont's most pressing problems. You can see the Act 167 report, as we all know, recommended some of these changes as well. So we appreciate you looking at this issue and considering this bill. Thank you very much.
Does anyone have any questions? I have a couple, but I'll certainly.
Question.
Indeed.
So just, I get your rationale and I absolutely get the rationale behind having these. What is to prevent like fly-by-night pharmacies just popping up? Like, what is the worst case scenario in your mind if there was no?
Well, in my mind, our worst case scenario is happening right now. We have a huge cost and an access problem. I don't see a lot of bad actors. It is not easy to just come and open a healthcare entity. And you have to, there's licensing, there's all kinds of things that you have to follow. So in my mind, we don't really have that problem at this point in time. We have a cost and access problem. So let's address that, the problem that's directly in front of us.
My mother lives down in Melbourne, Florida, and I brought her down there just a little while ago, and there are, like, every other corner has a pop-up pharmacy where there's lines outside of it. It just scares me that by doing nothing, it's just a thought.
I could be wrong, and maybe our healthcare advocate could correct me, but I'm looking at the list. We don't do a CON for a pharmacy.
Okay, and that was a bad example, but I
hear what you're saying. I do, yeah.
And we lived through a incinerator in Colchester that was burning medical waste products for a while. It's gone now, but it just scares me, the possibilities of how bad it could go. That's all I have to say.
All right.
We'll hear more about when we have the discussion using the introduction to the that chapter about CON, but I can say, like, overall, when CON started, I think it was originally with DSHCA, the Banking, Insurance, Securities, Healthcare Administration, thank you. And it was so that we had some oversight and regulation to prevent bad actors from using precious taxpayer healthcare dollars and making sure that you spent that money wisely and on systems and practices that Vermont actually needs. And so that there's oversight and protecting Vermonters from money, healthcare dollars being spent in ways that aren't helpful and harmful.
So the certificate, I'm sorry, can I just keep talking?
Yes, keep talking.
So we're revamping it, the initial, but you're not saying, or are you? Just completely get rid of it?
No, we're not. We're suggesting that the thresholds be increased. They're quite low. But certainly, big projects, it probably makes some sense to continue to review those in some form.
Okay.
Any other questions before I just have some specifics to other testimony that we've taken.
Okay.
So the Green Mountain Care Board is recommending regarding construction, they support 10 million.
Right.
The purchase of piece of diagnostic or therapeutic equipment, they've recommended moving that from 10 million to 5 million. And I'm wondering what your thoughts on that? And additionally, the 3 million for operating expenses from 10 to 3. So,
Yep. So, and that's part of the reason why I put this slide together, but we highly support the fact that the Green Mountain Care Board is recommending the same thresholds for hospital and non-hospital. As far as the amounts, we do feel that the 5 million and 3 million thresholds are too low for equipment and operating budget, but we're open to discussion, particularly if there truly is no review for projects that would come under these thresholds, then yes.
And additionally, just because we've had a lot of discussion, or maybe I've had a lot of discussion and nobody else has, the swirling topics in my head around what I'm terming reverse CON, or facilities that provide multiple types of care, that they would need to go through a process before they can reduce services. Wondering what your thoughts are on that. And additionally, with with our healthcare advocate yesterday or the day before, I don't know what day it was, around increasing the thresholds while at the same time maintaining some sort of application that would require review, that you would not, to say that you do not need a CON. To our healthcare advocates' concern about certain types of facilities and having some sort of check on that. Wondering what your thoughts were on his.
Yeah. First, for the reverse CON, the devil would obviously be in the details there. I mean, would that apply to private practice who, no longer can make their margins and have to close? I mean, how do you stop that when it's, or the Green Mountain Surgery Center? But I understand the thinking behind it. And then for the recommendation to have some sort of review for projects, I'm assuming under the threshold and over the threshold, I'm less enthusiastic about something like that because, it's a barrier. And if you're going to, unless it's some sort of attestation or something really simple, if you're having them do some sort of application, somebody's going to look at the application and then there's going to be questions and, it is a barrier, which, it will affect access, maybe not as much as our current CON, but I would more support not having a review for those under the 10 million.
Any other questions? Oh, Topper?
I'm a bit confused, so help me out on this. The continuing the CON conditions after the implementation period that we're talking about. Can you talk a little bit more about why you don't want to, you don't want to do that?
Well, as the data shows, CON is a barrier to entry that affects access. So any sort of process is going to continue to be a barrier to access. So if you're having, I just think there might be another way to achieve the goal if it's important to everybody except Medicaid, which, as this committee discussed earlier this week, it's not a black and white issue for everything. I'm trying, or affordability standards, rather than doing it through a CON process. I think there's other ways to achieve that, either through an attestation or something like that, rather than having the conditions continue, because usually the conditions, and they're, like the collaborative surgery center conditions, there were 28 of them. So it involves, a lot of work to do these implementation reports. So it just really depends on what is intended behind continuing the conditions. If it's just the affordability piece, maybe there's another way to tackle that.
So what you're saying is you're not against oversight, but you think it should be done a different way. Is that it?
Basically, for certain projects, I think I would still like to see really no CON process for those projects that are under 10 million. So that we have an access and a cost problem. CON is associated with decreased access, improved cost. So let's open it up a little bit, and, let the con isn't working as intended, so.
Okay, let me just bring it along further. It's a $10 million $1 project. So you do the CON. In that instance, are you against continuing the CON conditions after implementation?
Maybe all of it depends, A, how many conditions are attached to the project and what they are. But some of them I could conceive wanting to continue, such as the affordability standards, accepting Medicaid if it's appropriate in the particular case. So, yes.
So if I'm the person reviewing and you agree to all of the conditions,
Mhm.
wouldn't it be appropriate upfront to talk about what conditions are going to remain after the implementation?
Yeah.
I mean, isn't that part of the negotiations?
I wouldn't say that it's really a negotiation, the CON process. Yeah. The conditions are the conditions. You can appeal the conditions and you might get some relief from some of the conditions, but the conditions are the conditions. And some of them can be quite onerous.
I'm just confused. Because you're agreeing to those conditions in order to get, as an example, the surgery center in place and operating.
Yeah, I mean, because there's no other choice. If somebody wants to bring those services to Vermonters, they have to go through the CON, and the CON generally comes with conditions.
Yeah.
But it is a barrier. It is a barrier. And in fact, the Collaborative Surgery Center didn't happen in part because of the conditions that were attached to it. So it's a barrier.
Yeah.
Yeah.
So currently, certificate of need has a jurisdictional determination at first.
Mhm.
I'm looking at the form. There's the form in case you want to fill one out. Is that onerous? Is that too onerous, do you think?
And I don't recall the form, to be honest. I thought it was just you write a letter, here's what.
You write a letter, but they ask you for certain things. Description of the organization and what services, proposed project component, location, description of the service area, service, whether it's something to be expanded, replaced, or reduced, equipment that may need to be purchased, square feet, total project costs estimated, and how it will be financed, and essentially who's financing, who's owning it.
I mean, I think practically speaking, I mean, we're talking about increasing the thresholds to 10 million. So anyone would still have to, send in that jurisdictional determination letter to make sure that their project does fall under that. So I think it's reasonable. I mean, you'd have to have that information to go to a bank to get a loan to do the project.
Yeah. Okay. Any other questions? Thank you, Susan.
Thank you.
I may have misheard this, but I think there was concern that there wouldn't be any oversight of any kind for projects that would fall under the threshold, but there are other processes and licensing, and there's other oversight that has to happen. So it's not just this certificate of need process.
Sure. Thank you for pointing that out.
Would they have a list of criteria to deny a certificate of need. You know, I just hope that doesn't create a problem with, we don't want this outfit because we don't like them, or, you know, I don't know. There's just a lot I still don't understand about this.
I'm glad our legislative council is with us, because I think we have a lot of questions that maybe she can fill us in on, you know, other pieces within that process. Thank you.
Appreciate your time.
Thank you. And, oh, Shayla's on Zoom with us. So our next witness, Shayla Livingston, and she's going to talk about certificate of need in context with birthing centers, I believe. So welcome, Shayla. Thank you for joining us today.
Hi, everyone. Thank you so much for having me. For the record, I'm Shayla Livingston. I'm a member of the Vermont Birth Center Coalition and a resident of Williston, Vermont. I really, again, appreciate you having me. I'm sorry I'm not there in person. So I'm going to just provide some background, and then I'm more than happy to take questions. I come today as a Vermont resident and an advocate for reproductive choice in all aspects of reproduction. I'm a woman who has had both a wonderful home birth here in Vermont and a medically necessary high-risk hospital birth. I'll focus my testimony specifically on how certificate of need laws block access to reproductive choice when they are required for freestanding birth centers. So freestanding birth centers, for those who do not know, are separate from hospitals. They're very simple buildings. They're designed intentionally to feel like a home rather than a medical setting. They normally have 2 to 3 birthing rooms max, and those rooms, you know, have nice, comfortable furniture. They have often birthing tubs, but there is not any of the high-tech equipment that you would find in a hospital birthing unit. They're staffed by midwives who are already licensed here in Vermont, and they provide a really important part of the labor and delivery continuum from home birth to hospital birth. We are unfortunately missing them here in this state. I have submitted a fact sheet for you all, and I will also submit this written testimony. But in that fact sheet, you can find a lot more information about birth centers, and hopefully at some point we'll be back with midwives to talk about birth center licensing here. Very, very quickly, birth centers serve low-risk pregnancies. They provide safe and evidence-based setting for natural physiological birth. Vermont is only one of 8 states without a freestanding birth center. All of our border states have them. People delivering at freestanding birth centers have better outcomes at a lower cost. These birth centers are supported by private and public insurance, by ACOG and other national groups focused on improving perinatal outcomes and reducing costs of healthcare in the United States. They're even recommended by the White House White Paper on improving perinatal outcomes in the US. A really quick history of CON, just from this perspective. In the 1970s, Congress required states to adopt CON laws to be eligible to receive certain federal funding. So that was their origin. Congress realized fairly quickly that CON laws were not working. They were failed. And so they repealed that requirement in 1986. Since that time, every presidential administration has asked for CON laws to be repealed in states that still have them. 40% of the nation's population live in a state without any CON laws or very limited CON laws. And so it makes it easier to compare outcomes between those states that have them and those that don't. The overwhelming academic evidence shows that CON laws increase cost, decrease access, and decrease quality. And if you think about it from an economics perspective, right, that's what happens when you really restrict supply. States that have already repealed CON laws see the biggest benefits in rural communities. And I think this is the piece that is really important when we talk about access to care in Vermont, since Vermont is the most rural state in terms of we have the highest percentage of our population living in rural areas of any state in the nation. Very recently, a bunch of states have repealed CON requirements for birth centers. Connecticut, Georgia, Michigan, and West Virginia just in the last 2 years. Kentucky is partway through. They just passed a birth center CON exemption through their Senate unanimously. As a former longtime state employee, I have supported efforts to get state projects through CON. And I can tell you, as someone with years of experience in state bureaucracy and a master's in public health, and with a team of lawyers, it took us months and months to get a project through CON that had already been funded by the legislature and that was being demanded by this very committee. I don't want to think too much about how much you paid me to do that. And thank goodness we had awesome lawyers and administrative support to get through the process. A midwife looking to open a freestanding birth center in Vermont does not have that team of lawyers. They do not have that administrative support. They probably don't have very much time, and they definitely don't have the money to get through the process. CON laws are associated with fewer birth centers in states that require them. In the 13 states with CON requirements for birth centers, 62% have just 0 or 1 birth center in their state, compared with 24% of states without CON laws. So again, in the states that don't require them, you see many more birth centers than in states that require them. Reduced supply leads to lack of access to a model of maternity care that improves outcomes, narrows racial disparities, enhances patient satisfaction, and reduces costs to Medicaid and other payers, and of course, the people seeking the services. So we are requesting to exempt birth centers from CON. We are also requesting that the word includes be changed to means in section 1 of H96. Again, I'll submit this in writing so you'll have it there. This change would ensure that the financial caps are the only requirement for being exempt from CON. Unfortunately, without this, we have evidence from a number of years ago that the Green Mountain Care Board can require a CON for other reasons, because the list of financial caps currently starts with the words includes. And we use that word meaningfully in a lot of laws to allow regulators to expand the list if they see fit. I want to give a shout out to the Green Mountain Care Board that right now the current board is supporting freestanding birth centers, and that's amazing, and we really appreciate that. But that board changes and things change, and so again, we're looking for an amendment that either exempts birth centers entirely, and definitely that change that gets rid of the word includes so that it cannot be expanded. To finish, I believe in state oversight and regulation, and as I was just listening to the committee, right, there are so many different ways that we can work to make sure that Vermonters do not experience predatory medical, behavior. I have been, and I probably always will be at heart, a regulator. Birth centers should be licensed by the state. And there are 2 bills, one in the House and one in the Senate, that would do just that. That's it. Our job is to make sure Vermonters have access to reproductive choice that's safe and effective. And when we require a CON for birth centers, we are, in essence, pretending that we support them, but affecting a barrier that we know from data and from experience they cannot overcome. So I thank you for hearing from me today. And again, I'm happy to take questions. I've submitted a couple of fact sheets for you online, both about birth centers and about the issues facing birth centers with CON. And I will submit this written testimony as well, in addition to any information the committee wants in addition to that.
Thank you, Shayla. Any questions? I just have one, but any? Okay, I'll ask my one. So the freestanding birth centers, like as you were referring to, would you anticipate that they would cost construction over $10 million?
Most likely not.
Would their operating expenses exceed $3 million?
We don't know. We don't anticipate that. And so again, I think if the committee wants to keep, not do a full exemption and just focus on those financial limits, that works for us as long as the language is super duper clear that it includes. Okay. Because even when a midwife tried to get a CON exemption in the past and her estimates were under the old financial limits, the Green Mountain Care Board wrote her a letter that said she still had to do a CON. And also in testimony a number of years ago on a birth center licensing bill S204, Legislative Council confirmed that the Green Mountain Care Board could in fact include, again, which makes sense, that is the legal definition of includes. I've used it as a regulator, right? Other things in addition to the financial caps. And so that would, I mean, it really, that would be our need. So yes, we're okay with that, Madam Chair. If the committee makes that change and makes it very clear that it would just be the financial limits, we can probably live with that.
Thinking of another question, maybe because we've never taken tests on. Do we know approximately how many home births take place in Vermont every year?
Yes, we do. I can get you those numbers. I don't want to make them off the top of my head. Vermont has one of the highest home birth rates in the nation. We have a really strong home birth community. Unfortunately, we're seeing midwives have to retire or stop taking insurance, which is not what they want to do, because there are requirements for malpractice insurance that are making it really hard for them to survive financially. And then also, just like every other part of our medical system, we're seeing these providers age out and not be replaced by younger people coming in. And so I'll just take the opportunity, because you asked the question. Birth centers would offer the workforce an opportunity to both expand the types of settings that we have for workforce to come here and work in Vermont and ensure that we have an out-of-hospital option, even if there maybe isn't an opportunity for a woman who wants a home birth to have one. And so what I mean by that is, right now, we know there are midwives who live in Vermont and work out of state because they are not able to open a birth center here in Vermont. And so we are losing workforce, a critical workforce that we don't have enough of right now, to other states. And we are seeing women and pregnant people who would like to have a home birth, really having to travel long distances for that and have no alternative option to hospital birth in the state. But I will absolutely get you the numbers on the number of home births as a follow-up.
And if you could include also just an extension to the question, if we happen to know how many midwives how many births are delivered in a hospital setting?
By midwives?
Yes, by
Yes.
midwives.
Yep, we also know that. And we also have a really high rate of that in Vermont compared to the nation, which is great.
Daisy, Anna?
Great testimony, Shayla. This was really informative. I also had a home and one birth center birth. Can you also, when you're sending us statistics, share what the transfer rates are just for Vermont? If your group has those for home births that transfer to any local facility for assistance. Any other statistics just about the success or support needed of home births that your group has would be helpful.
Yeah, I can definitely do that. I do want to highlight, because I do know off the top of my head right now, the statistics for birth centers. So I do want to highlight that. There in the past have been concerns about safety with home birth or birth center births. And at this point, it is very clear. Again, ACOG is the American College of Obstetricians and Gynecologists, right? They are the OBGYNs of our nation. That association, along with many others, have really studied the data, and birth center birth is very, very, very safe. And in fact, has better outcomes for women than some of the hospital birth that we see. So the safety issue has been addressed. Transfers do happen. So about 15% of births in birth centers are transferred. Almost all of those are non-urgent. They're transferred because the labor is going on too long. The woman's exhausted. The woman has decided the laboring person has decided that they want to have some sort of pain medication that's not offered at the birth center. And those birth centers in the regulations that would be required under licensing have to have a transfer plan to a hospital. 2% of all deliveries are urgent transfers. So those are like something has happened that's unexpected. And so again, in Vermont, I would love it if in Vermont we licensed birth centers and didn't require CON, and like the next day, 10 birth centers opened. That is not going to happen. Like, we will be lucky if we can attract 1 or 2 groups of midwives willing to do this work. It is a labor of love. It is not a moneymaker. As the chair pointed out, the financial caps probably would not apply. So when you think about the impact on hospitals, the number of urgent transfers would be very, very, very small, like a handful a year, versus, and then the other part that I would say, I think another concern that has come up and a thought around CON is, well, will birth centers sort of steal births from hospitals? And there's no evidence that that would happen either. And in fact, if we offered birth center birth, we might attract, and we probably would attract, more births to the area that has that birth center. So, and that is what the experience has been in other places and spaces. Birth centers are not a replacement for hospital birthing units. We still need our OBGYNs, our midwifery-based hospital birthing practices, and would still require that in the state.
And in your, and Mari, just to follow up on some of the information you're getting to us, is there any research or studies around, I'm going to use complications or the safety between home births and birthing centers?
I can look into that and I will make sure that I have it right for you. Off the top of my head, though, when we look at this, the critical thing about safety for birthing people is that the birth is attended by a trained professional, which in the United States means they are also licensed, right? So we check the training through licensure. So by a licensed professional. So in Vermont, that means a certified professional midwife, a certified nurse midwife, or an OBGYN. The safety, that is the safety piece. If that is in place and there is a transfer plan in place, the safety is pretty parallel, I believe. The thing I will bring up is that unattended home birth, so home birth that happens when there is not a birth attendant available, licensed birth attendant available or there or present, is more dangerous. And one thing that birth centers could offer Vermonters and could offer us as we move forward into this new world of limited resources in terms of providers is ensuring that there is an out-of-hospital space for women and pregnant people who are not comfortable going to a hospital and could potentially choose an unattended home birth. So I want to be really careful that, like, when we think about safety, that is one of the concerns, is that we are limiting choices because we don't have this sort of, it's like a layer, right? Like home birth, certified freestanding birth center, and then hospital birth. And that fabric is really important to ensure that we are able to provide care to all different types of pregnant and parenting people. Does that make sense?
Yes, it did. Thank you.
Thank you, Shayla. When considering the conversation about whether or not birthing centers would reach the 3 million for operating expenses or 10 million, I think it would be helpful to have you help us paint a visual picture of what a freestanding birth center looks like. And I'm using a spectrum of like a hospital situation, which has all the tools for pretty much any kind of intervention, and really expensive tools for the intervention that's needed at the time. And then the other end of the spectrum would be a home birth, like you were just describing, without a healthcare professional. And freestanding birth centers are in the middle, but in my mind, they're more like the home, like if you're thinking about construction and how much equipment is in there and what operating expenses would look like, it's more like a home than it is a hospital with a bunch of equipment for intervention.
Absolutely.
So
So
go into detail about what it looks like.
sure, absolutely. So I think one really important thing is, and not to get marred in the licensing bill, but when we think about licensing home birth centers, I mean, the committee was just talking about what are all the different ways in which we regulate healthcare and oversee healthcare in the state. Licensing is a really, really important tool. And it's, again, one that we are coming and asking for in this case. In licensing and in the rules that the health department would put forward under birth center licensing would be requirements around the building and the environment to ensure safety, right? That said, so it's not that this is unregulated. I want to be really clear. It would be regulated. It would be licensed by the health department through the licensing standards. What it looks like and feels like, though, is you are creating a space that feels and looks like a home. So again, in Vermont, it would probably be 2 birthing rooms, right? You're not walking into a huge building. You're walking into a small building. There is no high-tech medical equipment. This is these centers are meant to support physiological natural birth. They cannot do epidurals. They cannot do C-sections. This is not a place with an operating theater. You're coming in to a space. There's often like really nice low lighting. There's often birthing tubs. There's big, nice beds. You're often discharged, if you would like to be, 4 to 6 hours after you deliver. You're not going to spend a lot of time there after you have the baby. And then the midwives come to your home often to do the follow-up care for postpartum and through your postpartum period. So it is meant intentionally to look and feel like a home, and it doesn't have a lot of that investment. So I think to the capital investment issue is very limited. The reason behind that, I just want to explain why that's important. So for birth to happen successfully, biologically, the person giving birth is most successful when they are relaxed and when they feel safe. And for some people, that's being in a hospital because that's where they feel safe and where they feel relaxed. For some people, that's in their home because that's where they feel safe and relaxed. And for some people, they would prefer to go somewhere else, right? But not be in a hospital setting with sort of the lighting and the lights and the noises. And I mean, I've come to you in a different capacity. We've talked about this for mental health, right? You don't want a mental health setting that has, that environment that can be triggering. And so in this case, it really depends on the person and what their history is and their culture is and what's going to make them feel supported. And for better or worse, what we know is that women who have experienced trauma, LGBTQ community, BIPOC people, they have experienced more negative things in our traditional medical system and often have much better outcomes in these birth centers because it's providing that very different environment and it feels and looks very, very different. So yes, I think, cleanliness is obviously really important. Comfort is really important, but you're not going to see, machines. You're not going to see an operating theater. None of those things are there. It feels much more like walking into a living room and then walking into a big, nice bedroom. Does that help?
Very helpful. Thank you.
And maybe Rep. Rebecca can, I never delivered in one, so I can't give you that personal experience.
I was going to add that the reason I felt safe choosing a birth center for one of my births was that they did have all the necessary emergency response equipment. So they had oxygen tanks and things like that, all there available, like, I don't know where it was, in a closet somewhere. If I needed it, and all the certified nurse midwives in their training, they were all like EMTs, or I don't know what the licensing was, but they were all trained for any critical situation that arose. And then they had to have their licensing where I was in that state had a requirement that they had to have a agreement with the closest hospital for transfer. And the hospital had a facility set up to do rapid intake if there was ever a situation arose. And like you mentioned, I had to have a transfer plan. So I felt incredibly safe.
Thank you. Yeah, I think, and that again, all of those pieces, I want to be really, really clear that Rep. Rebecca just mentioned are in licensure. None of that would be controlled by CON, right? That should and is and would all be in state licensing. So that safety requirements, the medical equipment that does need to be there on hand, right? They have the drugs to stop bleeding. They have the oxygen, like Daisy mentioned, so that those pieces are all in place and must be in place. And that is, again, controlled by the health department, who would have the regulations and the expertise to ensure that those pieces were there.
Mari, one more.
One more plug, for, I attended my daughter's home birth, by, certified professional midwives, and what Rebecca was just saying, I as a nurse, have a critical point of view when watching other people provide healthcare, especially to my daughter and my granddaughter. And she did have a bleeding episode, and I was so impressed with the midwives. They did everything right. My daughter did well. And yeah, they did a phenomenal job. They're highly skilled.
And I want to just back that up by saying, and just reinforcing this idea that what is most important is that you have a licensed, trained professional with you. One of the things that ensures the safety in home birth and in birth center birth is that the trained professional is with you the whole time. And that's not true in the hospital, right? People are left alone or have intermittent nurses come and check on them. This is not, I am not degrading the hospital care, right? But that is different than having the person responsible and licensed to deliver the baby or catch the baby, the parents delivering the baby, there with the person who's delivering. And like Rep. Cordes just said, will immediately address the issue because they've been watching the total progression of the delivery. They know the full history of the person, and they are ensuring that that progression and that history is all taken into consideration in responding to an issue and can respond immediately. And so when we think about these levels of care, you know, and you think about, well, it must be less safe because it's further away from an OR. It's actually not, because you have that person who is there the whole time and is able to respond immediately and monitor the situation constantly.
Okay. Yeah. Rebecca just said, we could talk about this all day.
No, I can talk.
Oh, thank you so much, Shayla. Thanks for coming in, and we appreciate it. So I think we can go off of live now.
Thanks all. Happy Valentine's Day.
Thanks, Shayla. Good
Oh,
to see you.
Thanks, Shayla.
No, I think you just have to.
Oh, okay, go choose later.